Welcome to In the Thick of It from the HCMS Society, a show that dives deeply into hypertrophic cardiomyopathy with leading experts in the field. We explore groundbreaking research, new approaches, and other exciting topics. Please enjoy today's discussion supported by an unrestricted educational grant from Bristol Myers Squibb. Welcome to the In the Thick of It podcast. I'm pleased to welcome everybody to season 3. We're excited. We're going to have some new faces on the podcast this year. And we'd like to get the season kicked off with a discussion about the HCM Society meeting, which occurred last Friday, November 7th in New Orleans. So just to introduce myself, I'm James MacNamara. I'm a hypertrophic cardiomyopathy and imaging specialist at the University of Virginia. And I'd like to introduce my co-host, Betty Raman. Betty, could you introduce yourself?
Sure. So I'm Betty. I'm an honorary consultant cardiologist at Oxford University Hospitals, NHS Trust, as well as University of Oxford. I have expertise in inherited heart diseases as well as cardiovascular imaging, so both cardiac MR as well as CT. I'm also an associate professor of cardiovascular medicine here and a Wellcome Career Development Fellow.
Fantastic. Well, Betty, thank you so much for being with us today. Looking forward to an exciting season of topics on the In the Thick of It podcast. So first, let's start talking about the Hypertrophic Cardiomyopathy Society. I imagine that many of the people watching or listening to this found us through HCMS, but for anyone who didn't, the HCMS is a multidisciplinary group of kind of the coalition of people who take care of patients with HCM. A lot of physicians, we have advanced practice providers, pharmacists, sonographers, the whole kind of gamut. And every year, or for the last 4 years, I should say, we have had an annual meeting. Last year was particularly memorable because it was supposed to be in Atlanta on the one day each decade that Atlanta is hit with a hurricane. So we had to be virtual. This year, the meeting was successfully held in person, though we did have the adventure of all of the FAA flight situation, but I think we got everybody there, right?
Yeah, absolutely. I think we were fortunate enough to make it there on time and not miss any sessions. So it was actually really terrific. And it was great to have such a diverse group of speakers from across the world, James. So what was the most memorable moment to you really from this meeting?
Yeah, I think that there are two that stick out. Well, the one thing I will say definitely stuck out was when Milind Desai was showing young pictures of a lot of the HCM providers. And they showed Steve Ullman and a picture of him in his office, picture of him, where he apparently is the Brad Pitt of the HCM Society meeting. So that got a good chuckle. I think that one of the big takeaways for me was how much HCM is a team sport. We heard a lot of different perspectives from a lot of different people. The pediatric side, which I'll confess as an adult only doctor, I tend to not think about as much as they have to, they're diagnosing these patients, they're taking care of them when they're kids. And then I think that panel really spoke a lot where we talked about, the role that everybody plays. One of my dear friends, Aaron Davidson, was a pharmacist on that panel. Sue Ospina, who you guys will hear on this podcast through the season, is a nurse practitioner at the Cleveland Clinic, was on that panel. And it really just kind of showed how we're a team sport. And it takes a lot of different people to take care of these really fantastic patients. How about you? Anything that really kind of particularly struck out for you?
Well, I'd have to say, so I found the whole session extremely fascinating. It was really exciting to see how people from different realms and different aspects of the care were able to share their experience and were passionate about the work they were doing. For me, what really stood out was the talk by Professor Hugh Watkins. So he was invited to give the inaugural Bronwell lectures, as you know, and he in a short space of time was able to elegantly capture the breadth of work, the breadth of research he'd done, and the way his work has really changed the way we think of hypertrophic cardiomyopathy.
Yeah, I was really impressed by that. And particularly right now, gene therapy, we're hearing a lot about it. It was exciting the next day at AHA to see some of the early Tenaya results that at least the patients were safe and well tolerated. Um, of course, from an efficacy standpoint, there's a lot to be learned. But one of the things I really took away from Dr. Watkins' lecture is that gene therapy isn't one thing. And it's not one approach. It's not just the success or the limitations of AAV9, which someone out of the gene therapy space, I kind of worry about AAV9. But the fact that they've got these brilliant people, I knew Eric Olson through my time at UT Southwestern, and all these brilliant people working on this problem from multiple angles is really reassuring that this is going to be a technology that we'll see during our careers.
Yeah, indeed. No, I mean, he's working on lots of different aspects of delivering curative treatments. So I suppose one of the big challenges we have when you talk about gene therapy is how one can predict who is at risk of developing the more aggressive form of disease. So we know that penetrance can be quite variable. And how does one do that? And he very eloquently articulated this when he talked about his work, where he was the first to show that the influence of polygenic risks and how that might impact penetrance in hypertrophic cardiomyopathy. Specifically, there was a paper that he published in Nature Genetics in 2021, where they showed that a number of common variants contributed to disease expression, and the effect of this polygenic burden, was greater in sarcomere-negative HCM. And this certainly changed the way I think of sarcomere-negative HCM when I see a patient in clinic. This also has relevance for family in terms of screening family members. Typically we might offer screening to a first-degree relative, but beyond that, it's clear that the risk is significantly reduced, particularly in those in whom we believe have a polygenic form of disease.
Yeah, I wanted to ask you about the polygenic risk scores, because I'm sure you see, and I'm sure, everybody who's listening, when they see patients with HCM, we see the patients, they're older, they've got kind of the classic metabolic comorbidities, their genetics are negative, but their heart sure look like hypertrophic cardiomyopathy. And I wanted to ask you, do you think we're going to see polygenic risk scores as a diagnostic technique? And if so, in what kind of a timeline would you envision?
Yeah, so I think this space is quite exciting. The work of James Ware and Hugh Watkins, and a number of other people in the space suggests that actually we have a lot more to uncover. So with larger data sets, meta-analyses of big genotype data sets, we are able to discover a lot more loci that contribute to the risk of HCM. And with greater knowledge in the space and sharper tools, polygenic risk estimates, we might be able to administer this in clinic and say, actually, you have a high chance or high risk of actually having a more penetrant form of disease, and therefore might need closer surveillance, and we may offer further sort of screening in family members. So I do think there is a place for this, but at present we're still uncovering the role of these variants. And I think this work has really opened up a lot of excitement in the field, particularly in uncovering new markers that can influence penetrance, any new gene or variant that might contribute to penetrance. Professor Watkins also talked about how some new genes were discovered where rare variants or a monogenic form might contribute to disease expression, like SVIL. As I said, the space is only just beginning to open up, and I do think there's a lot of biological experiments that need to be done as well to further understand how these common variants influence disease.
Yeah, it's one of the things I really liked about the meeting itself is, because it was the whole day, one room, world's experts in hypertrophic cardiomyopathy, we were able to kind of touch on the whole gamut, from imaging to the genetics, which is, not my strength. So it's always great to learn what the current practice and then the next phase of genetics is going to be. And then there was just fascinating. The afternoon really focused in on treatment.
Yes, absolutely. Just working on or talking about gene therapy, I think the other aspect of developing gene therapies that Professor Hugh Watkins touched on was the approach that people are using. So they're also identifying novel ways to target and manipulate gene expression. One way that he talked about was obviously RNA therapies that are currently out there in the market, but specifically using antisense oligonucleotides, which can essentially silence the mutant allele, which may be particularly helpful in people who have dominant negative variants that contribute to disease expression. So there's lots of new avenues with gene therapy, and I must highlight that a lot of this work is being supported by charitable funds from the British Heart Foundation, and it's a very collaborative effort across the Atlantic and between experts from both America as well as the UK, and we're quite excited to see, this unfold in our time.
Yeah, absolutely. And I want to change gears just ever so slightly, because one of the other real highlights of the HCM meeting was the debate. And I'll put kind of debate in quotes because it was it was not fierce. Anyone who was expecting sparks to fly, but there was a debate between Matt Martinez and Steve Ullman about how to take care of the refractory patient with HCM. They're on the beta blocker, they're still having symptoms. And Matt was assigned or asked to talk about the medical therapy, and Steve was asked to talk about intervention and surgical therapy as kind of to advocate. And part of the reason why there wasn't a big disagreement is because I think we're clearly in an era of shared decision making with the patient, where we're able to, I think that there's some on us as the physician to identify phenotypes, characteristics, risk profiles, things like that to say, okay, no, maybe surgery, even in an expert center, could be quite difficult. Those big reverse curvatures where you're deep into the septum, people with existing conduction disease, or, maybe we don't do the CMI, maybe we've got a drug interaction, maybe REF's tenuous. But really we can present patients these options and hear their input. And I think both of them, would be perfectly happy for a patient to choose a CMI or for a patient to choose septal reduction therapy. And I wanted to ask you kind of how you go about that discussion. I know briefly, we don't have a ton of time, so that's probably an hour-long discussion in itself.
Yeah, absolutely. I think that was quite refreshing to see. And I must say that the surgeons who were invited were fairly confident in their ability to potentially resect or treat these patients effectively. But equally, they seem to embrace the idea of people picking cardiac myosin inhibitors in some circumstances and their services being more catered to people with specific morphology. Certainly in our center, we don't have surgical expertise, so we look forward to referring our patients to places that have, the critical mass or in terms of patient experience to do these procedures. And it really does matter that the surgeon has done enough cases. And yeah, so I think this is an evolving space. I'm also curious to know how cardiac myosin inhibitors will impact risk stratification, particularly sudden cardiac death risk, because we know that in the European Society of Cardiology, there's left ventricular outflow gradient is an important risk marker that contributes to the estimated sudden cardiac death risk over 5 years. And similarly, left atrial diameter is also another continuous measure. And we know that both these measures do improve with cardiac myosin inhibitors, and how this new generation of treatments will influence risk in our patients is something that must be investigated.
Yeah, and that was a really fantastic presentation later in the day, kind of comparing and contrasting the American versus the UK approach. And I do wonder, it's the regression equations, the gradient is so small for how it influences risk. But given that patients feel so much better and their hearts just look so much better,
Yes.
I would love to see that data. And to see that we see less risk. I know that was going to be a challenging thing to study, but definitely something that hopefully is on the horizon.
Yeah, probably something that they can do as a meta-analysis. So I know that BMS as well as cytokinetics are gathering long-term data. And so it might make sense to pool data from different studies to answer that question. On the topic of risk, I'd like to get your thoughts. I mean, you gave a very great talk on exercise and how we've changed we've shifted the way we think of exercise in hypertrophic cardiomyopathy and its interaction with risk. Would you like telling us a bit about your thoughts on this?
Yeah, that was my pleasure. I was so happy to give that talk. And to boil it into a nutshell, a lot of the discussion at these meetings is surrounding exercise, at least focuses on the athlete. And the athlete is an incredibly important person. We have to serve that population. We have to make sure we're helping them and making good decisions. So I wanted to find a way without denigrating the athlete to shift the focus a little bit to the patients that the majority of our colleagues are seeing. Certainly, the vast majority of my patients aren't athletes, though I saw a gentleman this morning who does triathlons. But, most people, they just want to exercise or they're afraid to exercise. And that's been a fear that is well-founded in our history, but isn't supported by the prospective data. We also, we had a whole session that Anjali Owens gave that was fantastic about the current state of non-obstructive therapies. Well, there is one therapy that is proven in multiple randomized clinical trials to improve fitness and improve quality of life, and that's exercise training. And moderate intensity exercise really seems to be what has kind of shined. Certainly higher intensity exercise have been performed. I'm really interested as to why there was a limited returns on that increase in intensity. But we now have 4 randomized controlled trials in a population of primarily non-obstructive patients, where in each one, exercise has been safe and effective. Of course, from a safety standpoint, small RCTs isn't the way to go, kind of hearkening back to what we were just talking about with CMIs. How do you prove that they reduce cardiac arrest risk when it's so rare? Well, same thing. And that was the LIVE HCM study, really showed that patients with HCM do have cardiac arrest, arrhythmogenic syncope, ICD shocks, but there was just no difference as to whether or not you were exercising or not. And that may be the study design that's needed over time for the CMIs as well.
Absolutely. And on the topic of exercise, I think healthy lifestyle and ensuring your weight is within the normal range is also helpful, because we know from the work from Professor Watkins that BMI has an influence on penetrance as well. So genetically predicted BMI, if you were to use a genetic instrument to assess someone's risk of having high BMI, that can influence penetrance. So I think overall the benefits of exercise goes well beyond its metabolic benefits, but also the effects of weight loss on wall thickness and penetrance.
Yeah, and I think that's, for me, the next big question in the exercise space is going to be, do we see the same benefits for patients with HCM that we see in the general population? Now, the fact that we and others saw less fitness improvement with high intensity exercise gives me some pause in that HCM patients may need a different either quantity or a different exercise prescription than a patient without. It was fantastic reviewing, kind of talking about the meeting. I hope that anyone who's listening who wasn't able to attend or didn't know that the meeting was happening will be interested in coming and joining us next year. Just remember to get those seats early. The HCMS meeting has a habit of selling out in a good way, not a bad way. But Betty, any kind of parting thoughts before we end the episode?
No, just to say that we're really excited with all the research and all the engagement that there is from patients, but also from clinical experts from various domains. And we really look forward to hosting more of these sessions with you.
Absolutely. Thank you. And I think for anyone listening who doesn't have a large volume of HCM patients, we can go really, really deep on these topics. But at the end of the day, we're taking good care of patients. And I think the HCMS Society meeting, the big takeaway is how many people are working so hard to provide good care. So for any of our audience who are part of that community taking care of these patients, we want to thank you. And thank you for listening to this episode of the In the Thick of It podcast. Thanks for joining us on In the Thick of It, presented by the HCM Society. Make sure to subscribe to our show for more expert insights into the field of hypertrophic cardiomyopathy. For more information, check out the links in our show notes. We hope you will join us again for our next episode.